Hi, I'm Todd Allen, and I serve as the Senior Executive Medical Director for the Healthcare Delivery Institute at Intermountain Healthcare. Several times during the advanced training program in clinical practice improvement, we've made the case that physical outcomes, or for healthcare, clinical outcomes, directly relate to cost outcomes. We've argued that they, clinical and cost results, are two sides of the same coin. That is, they are simply outcomes of a process where, once you more effectively manage the clinical process to achieve new and hopefully improved results, that quality and cost are intimately intertwined, meaning you can't really change one without changing the other. We have also tried to make the case that they are directly and causally linked. The causal link between quality and cost is an interesting idea that is still relatively new to medicine. Well, today our purpose is to explore those interactions more directly in order to show exactly how they are directly and causally linked. In laying out this theory originally, Dr. W. Edwards Deming defines three hard causal mechanisms by which cost and quality are tied together. In this video, we will walk through each of those three mechanisms and then consider the implications of the total theory as the intertwined nature of each of these mechanisms become more apparent at the end of the video.
As always, I would like to start this section with a good clinical example. In 1986, Dr. John Burke and his team in infectious disease at LDS Hospital began to study the second most common source of patient injury and death in a hospital. It's postoperative deep wound infections. They laid out a classic conceptual flow diagram. At the highest level, they attempted to prevent infections in the first place, then to detect those that did occur so that they could treat them. They decided that their biggest opportunity came in the prevention step. Prevention itself had 4 sub-steps. Number 1, patient preparation before surgery. Number 2, the use of antibiotic prophylaxis during surgery. Number 3, sterile technique within the surgical procedure itself. And finally, post-op wound care. The team determined that their biggest opportunity was with antibiotic prophylaxis. Now the idea is that you give antibiotics in conjunction with surgery, aiming for high tissue and blood levels of the antibiotic so that if bacteria do enter the surgical incision, the first thing they encounter is the antibiotic, which forthwith kills them, which means no infection. Within prophylaxis, there were 3 further steps at the next layer down. Number 1, select the patients who will benefit from the use of the drugs. Number 2, choose the best antibiotic for that particular surgical procedure. And finally, deliver the drug. In conjunction with that last step, Dr. Burke and his colleagues had developed some important new science. They had demonstrated that there's an ideal time at which to start antibiotic prophylaxis. That ideal time window was initially defined as within 2 hours before surgical incision time. If you started antibiotic prophylaxis within that time window, infection rates would be substantially lower than if you came earlier or later in the process. In fact, they published their results in 1992 in the New England Journal of Medicine in a major article that it's fair to say was the trigger for our nationwide surgical infection prophylaxis efforts today. This slide demonstrates the results of their initial investigations. They discovered that when they did give prophylaxis, they gave it in a timely way only 40% of the time. Now, just to get that in perspective, using a research quality tracking system, their deep post-op wound infection rate was only 1.8%. When I say a research quality tracking system, they were tracking patients well after they left the hospital, contacting initially the surgeon, and if the surgeon couldn't supply complete information, going directly to the patient. Most hospitals who track this statistics rely just upon inpatient infections, those detected during the initial hospital stay. That means that Dr. Burke's detected infection rates were substantially higher than that usual method. Well, yeah, it turns out that essentially all hospitals do track this statistic. It's required by the Joint Commission review process. This is one of the reportable statistics every hospital has to generate. Again, to put it in perspective, the Joint Commission scoring guidelines said that a good hospital would have a rate between 2 and 4%. In other words, Dr. Burke's performance was better than the best national standard. How would you respond in that circumstance if you recognized that your current performance was better than the best national standard? most people would say were good enough and go on to some other topic. Happily, Dr. Burke and his team did not do that. Instead of looking at the 1.8% infection rate relative to a 2% best national standard, they instead looked at that on-time prophylaxis rate and said, wait a minute, 40%? Does that represent good performance? They therefore initiated a series of interventions designed to improve their on-time prophylaxis rate. It took us about 6 or 7 years to test 6 or 7 major interventions. The first one, Dr. Stampa Stocknick, a PhD pharmacist, would arrive in surgery before the start of the surgical day. He would review each case and place a large Day-Glo orange sticker on the surface of the metal chart cover. It would basically recommend prophylaxis, the ideal antibiotic, say started on time. Despite the fact that they had worked with the surgeons and the nurses in preparing this intervention, it failed within the matter of a couple of days. The nurses didn't care for the implied criticism of their nursing processes. More important, the surgeons thought that it might convey some sort of legal liability. Suffice it to say, within just a few days, it was gone. Their next test involved an alert system built into the electronic medical record at LDS Hospital. On a particular time clock, a visual klaxon, a flashing xenon light, would start to flash on top of the ward clerk's terminal. They'd take over the screen with a flashing screen that said, start antibiotics on patient X, who was scheduled to go to surgery. That one too failed, mostly because it was so irritating to have the flashing light. You know those little pieces of tape that nurses tape to their scrubs as they work each day on a hospital floor? They found a better use than just carrying them around on their uniforms. They began to tape them over the light so you couldn't see the light. And I guess if a little of something's a good thing, more is even better. You ended up with these balls of tape on top of the ward clerk's terminals. I mean, literally a foot in diameter. Somewhere in the center of that ball was a little flashing xenon light. Well, that one failed. The third intervention, though, had some effect. The team began to work with the nurses directly, had the nurses implement changes. It was centered around start prophylaxis on call to the OR, and that actually improved performance. As you can see, between 1985 and 1986, the rate of appropriate prophylactic antibiotics increased from 40%. They continued down that chain. It was not until 1991 that we finally reached the point of having the anesthesiologists start prophylaxis after anesthetic induction. Now, the anesthesiologists don't like to introduce a new drug during induction itself. A potential allergic reaction at that very labile time period can be dangerous, to say the least. But under their control, they get the patient stabilized, start the prophylaxis, and that's when we started to hit high 90s in terms of our on-time prophylaxis rates. Well, you can see what it did to the overall infection rates. 1.8% better than best national standard in 1985, but by 1986, with some of these interventions, it had fallen to half that, to 0.9%. When we finally started to hit the high 90s, we started to show rates right around 1/2 of 1 percentage point. In fact, in 1991, it was 0.4%. Oh, could I just point out, that's 5 times better than the best national standard. Now in passing, it's worth remarking, very often national standards don't measure excellent performance. They're a minimum threshold. They're certainly not a measure of excellence, merely a measure of adequacy. In choosing the areas you want to attack, in setting priorities, that's a concept that's worth remembering. We knew that it saved money. The legitimate criticism of Intermountain in the intervening years is that it took us almost 10 years to decide administratively to make it so. You see, for those first years, we just relied upon our clinical teams, the physicians and nurses, to spontaneously adopt this obvious clinical benefit, and a few did, frankly. Some of our big hospitals implemented similar processes. When we checked in 2001, though, we found that our overall infection rate was still running about 10 infections per 1,000 opportunities, about a 1% rate, and we knew it was too high. It was not until then, when the Board of Trustees said, make it so, that we finally acted to implement across our system. This slide shows the impact across all of Intermountain, across 2,400 hospital beds, 22 facilities, when we took that final step. Yeah, we watched our infection rate fall by half yet again, from about 9 infections per 1,000 opportunities down to about 5. You're looking at an additional $3.5 million in net cost savings across our system in 2002 dollars. I think we would all agree in looking at these data that John Burke's team achieved a better medical outcome. That fall in infection rates translates into, well, not just suffering, but into lives. In December of 1987, I had attended a course offered by Dr. W. Edwards Deming at the Hotel del Coronado in San Diego. After 4 days of listening to him describe manufacturing processes, one thing came through profoundly. He made the argument that as you improve your quality, it would cause your costs to drop. I came home from that course, went straight up to Dr. Burke and the project ongoing at LDS Hospital, and suggested to John that it might be interesting to track cost outcomes. He'd had a similar interest, but we had a major advantage compared to most other places in the United States. We were actually able to directly measure cost. Steve Busboom, our Vice President for Finance here at Intermountain, and Greg Polson, now our Senior Vice President for Planning, had developed one of the world's first activity-based cost accounting systems. We used that to carefully examine the additional marginal costs associated with a deep post-op wound infection. The number was surprisingly high. We estimated $14,000 per event. How could it be so high? Well, remember, it wasn't just those abdominal wall infections after some sort of peritoneal surgery. It was those deep mediastinal infections after open heart procedures, infections that result in an open sternum, trips to the ICU, very often high risks of death. Put a few of those into your mix and see what it does to your total costs. Well, the way we did the cost calculation, we just said, okay, in 1986 with a 0.9% rate, that was 33 fewer infections than we would have had if we'd followed our old, better than national standard 1.8% rate from the year before. 33 infections at $14,000 per infection, that was almost $500,000 per year in net cost savings. Costs that we never incurred because we never had the infections in the first place. By 1991, it was pushing $750,000. Well, wait, that's conservative. First, I had not adjusted those figures for inflation. The cost of treating a deep wound infection had actually increased in the intervening years. Second, when I ran the data, I only had 10 months worth of hard figures from surgery. I thought initially to increase the counts by extrapolating to a full year, then thought, no, just to be conservative, let's just leave it for 10 months worth. So 51 cases, probably should be more like 60. Accounted for in inflation, non-adjusted dollars, about $750,000 a year. I think we'd all agree, a better medical outcome associated with a significantly lower cost. Well, in quality improvement theory, that phenomenon has a name. It's called quality waste. Quality waste is the first explicit mechanism by which physical outcomes interact with cost outcomes, and you need to know it. It's one of the most important concepts you'll gain from the course. Here's the theory behind it. Well, it's all based around processes. Imagine that you have a process and that a step in your process fails. Not every time, but a proportion of the time, that process failure will lead to an outcome failure. What can you do with your outcome failures? Turns out that you only have two choices in the world. Number one, you can fix it. Treating the infection is fixing the initial process failure. Number two, I guess if it weren't a human life, you could discard the failed product, the product that has no use or utility. An illustration. Back when I was working with Dr. Deming, this concept came up, and he pulled a piece of paper out of a stack of papers he had on his desk and handed it to me. He said, "What do you think?" Well, when you read the text, you discovered that it was an ad from a major spark plug manufacturer. Turns out that this spark plug manufacturer individually inspected every spark plug that came off their assembly line before they sold it. 100% inspection. If the spark plug passed inspection, they boxed it up, shipped it out, and sold it to the likes of you and me. If it failed inspection, it went on to this pile. Well, Dr. Deming shows me the ad and says, "What do you think?" I thought the answer was fairly obvious. Thinking as a physician, I said, well, I guess if I buy one of their spark plugs, by definition, I get a high-quality spark plug, right? It's been individually inspected. Of course, it was a trap. As soon as I said that, Dr. Deming replied, "Yeah, but who pays for the spark plugs in the pile?" Now that's an interesting question. Who does pay for the spark plugs in the pile? I mean, it takes exactly the same amount of materials to manufacture that spark plug, the same amount of processing, even the same amount of inspection. Who does pay for it? Yeah, I do. If I buy one of their spark plugs, they have to build those costs into the total costs of the products that they finally sell. That's quality waste. Business Week magazine estimated that American manufacturing industries contained about 25 to 35% quality waste across the board. Oh, that was at a point in time when Japanese companies going head-to-head with those American companies in competitive markets would have quality waste rates of well under 1%. See, that was a Japanese strategy, the first major competitive business strategy based around quality and cost. Their term for it was move upstream, or sometimes they called it do it right the first time. Rather than allowing a process to fail, then recovering after the fact, move upstream into the process and manage the process so it doesn't fail in the first place. As a result, they were producing products that were higher quality, far lower failure rates, and at much lower costs. They didn't have the price of that, well, rework or scrap built in to their work processes. In 1991, Anderson at Chicago measured quality waste in American hospitals. In a fairly rough estimate, he put the number at 25 to 40% of all cost of operations. More recently still, we just completed an analysis for the Agency for Healthcare Research and Quality. Our estimates place quality waste at more than 50% of all costs of operations in American hospitals right now, today. Quality waste is the first mechanism by which your clinical outcomes relate to your cost outcomes. With quality waste, as your clinical outcomes improve, it physically causes your cost of operations to fall. The second mechanism is related. It's called inefficiency waste. The technical definition requires a little bit of an artificial construct. Imagine that you have two processes side by side. That's critical. Those two processes take identical inputs and produce identical outputs. That's critical too. But one of the processes uses fewer resources to effect the transformation. In other words, it's more efficient. It achieves the same goal from the same starting point with fewer resources. Well, which one should you use? It's obvious, isn't it? You ought to use the one that's more efficient. The world's expert on inefficiency waste was Dr. Harry Roberts at the University of Chicago. Unfortunately, Harry died a few years ago. Just in passing, he wrote a classic text called Quality is Personal. It's well worth the time to read and understand. His interest was, though, inefficiency waste. He estimated that at least 50% of every process was inefficiency waste. Just to illustrate with some of the examples that we've used in other parts of the course, remember those quality, utilization, and efficiency studies that we shared with you? The first one that we examined in detail was for transurethral prostatectomy. Within that, after very carefully balancing across patients, so it was a fair comparison, same patient in, same patient out so far as we could tell, we showed more than 100% cost differentials across a group of 16 urologists. A low of about $1,150 per case, a high of almost $2,300 per case. I pointed out that among the 6 conditions that we measured back in 1986 and 87 using this methodology, that was typical to see a twofold difference in cost. Now, in fairness, We initially couldn't tell if this was really inefficiency waste or, well, arising from our inability to statistically power our studies sufficiently to detect real differences in complication rates. Since that time, though, after we saw the care change, we're very confident in stating that, yep, this was just inefficiency waste, a different process that achieved the same good end with substantially fewer resources. In an earlier part of the course, we shared a second good example of inefficiency waste. We were examining cases that came out of open heart surgery, usually on a mechanical ventilator. The first job of the nurses in the thoracic ICU was to stabilize their cardiac condition, but then to wean them from the ventilator. A fixed period of time after they were weaned, they were discharged out to the floor to complete their recovery and go home. Well, as we stabilized the care, mean time on a ventilator initially fell from about 25 hours to about 10 hours. Today it's about 4. That first fall, though, of 15 hours, wait a minute, that means that 60% of ventilator time was inefficiency waste. 15 of 25 hours gone, just by stabilizing the process with the same good clinical outcome. Oh, as you may recall, that was associated with a significant fall in length of stay in the thoracic ICU, a 30% fall in length of stay, which was in turn associated with about a 15% fall in the total cost of doing open heart surgery. About $3,000 per patient, but you have to remember, we do about 2,000 of those a year across the Intermountain system. That represented net, after all of our expenses were paid, about $5.5 million per year, translating ahead in the years since as financial advantage. That's inefficiency waste. While quality waste announces itself, you just have to learn to watch for muda, to watch for rework and scrap in all aspects of work. Inefficiency waste does not. That makes it very, very difficult to approach. You don't know you had it until after you've solved it. With quality waste, as your quality goes up, your cost goes down, a win-win. With inefficiency waste, your quality holds stable while your cost goes down, a win break even. Or if you take those resources and feed them back into the healthcare delivery system, your quality goes up while your cost holds stable. The third area is not so attractive. With cost effectiveness, as your quality goes up, your costs go up, a win-lose. The best way I know to describe the concept comes from Dr. Avedis Donabedian. Dr. Donabedian was a Lebanese physician who emigrated to the United States many years ago, started a research career in health services at the University of Michigan in Ann Arbor. He was a truly beloved figure. Generations of young health services researchers learned at his feet and respected him throughout his life. Well, this comes from an article that Dr. Donabedian published in the Journal of the American Medical Association in 1988. He created artificial circumstance side by side to illustrate two different ways of thinking about care delivery, two different approaches. Model number one, he said, imagine that you have a patient who comes to your hospital and that you decide that you're going to spend the same amount on that patient each day, a constant rate of increase in health care costs, $1,500 a day, let's just say for the sake of argument. Well, as I begin to treat the patient, I'm going to do the things that work best first. And as I apply those treatments, I'll get a health benefit. So a benefit curve will start to rise fairly steeply. The problem is that I will exhaust my first-line treatments and be forced into second-line treatments. I'll exhaust those as well, be forced into third-line treatments. As that occurs, the slope of the benefit curve will inflect, flatten, and finally hit a maximum. What we actually know is that if you continue to treat past that point, total benefit goes down because of the risk inherent in any treatment where there is no additional marginal benefit for that patient. But assume just for the sake of argument that I can titrate perfectly, right to point B. At this point in time, this level of costs, this particular level of benefit. Dr. Donabedian would call me a maximalist because I seek maximal benefit for the patient seated in front of me. Having established that particular artificial construct, theoretic approach, he placed a slightly different one side by side. He said, you know, a very useful measure in this circumstance is something called a cost effectiveness curve, or sometimes a cost benefit curve. Now, on this slide, that's not a minus, it's a hyphen. It's not cost minus benefit, it's actually the slope of the benefit curve divided by the slope of the cost curve. That's why he constructed this artificial circumstance. He wanted to make the denominator a constant so that cost increased at a fixed constant rate. Well, the cost benefit curve climbs steeply, inflects, hits a maximum, and then moves down. In fact, the original article contained a small error that no one noticed, probably because it didn't change any of the conclusions of the article. It should have gone down to zero, because where the slope of the benefit curve was flat, was zero, well then the cost benefit curve has to return to zero. Well, here was the point. You can prove mathematically to obtain the best possible medical outcomes across a population. You have to be at the peak of the cost-benefit curve. That was the major differentiation between the two models. In the first, you were thinking in terms of a single patient seated in front of you. In the second, you're thinking in terms of a population of patients, let's say 50,000 covered lives who are paying an insurance premium. You have a fixed, limited budget to deliver care. Think of it this way. Imagine that I'm treating a patient who's in the right-hand side of their curve, where that cost-benefit curve is dropping back down towards zero. Well, as I add 1 unit of care, that additional $1,500, move 1 unit to the right, how much does the benefit curve go up? It's very, very small, a tiny amount, where the curve is almost flat. Imagine, though, that I took those same resources and found a patient instead who is over in the left-hand part of the cost-benefit curve. Well, there, when I move 1 unit to the right, I get much more benefit than I get for somebody who's over in the right-hand side of the curve. Again, you can prove mathematically to get maximum benefit across the population. I have to titrate so that I'm at the peak of the cost-benefit curve. Don Abedian would call that physician at point A an optimalist, because they seek optimal care across the population as opposed to maximal care for a few individuals within the population. Of course, as he went on to point out, the most interesting questions arising from this analysis are ethical in nature. Most American physicians believe that our primary ethical consideration is to achieve maximal benefit for the patient seated in front of us. It turns out you can arrive at the same ethical circumstance, though, in the population level as well. Dr. Don Abedian called this the optimalist-maximalist argument. Our best examples of it are new technology. I get that new scanner, that new breakthrough in technology. Yeah, it gives me a better ability to see what's happening inside of a patient's head, a better ability to detect a mass lesion, to perhaps improve treatment, extend life. But then I'm forced in that very difficult circumstance of judging whether this much improvement in clinical outcomes justifies this much increase in cost. Now, that's where it extends into core ethical considerations. Most American physicians are trained to think in terms of the individual patient. We hold our primary ethical commitment to be to that patient seated in front of us. Our goal is to achieve maximal benefit without consideration for any other factor except that patient's health result. Turns out when you move it into the population arena, it changes the nature of the question. There you have to ask patients how much they're willing to spend to achieve that result. In fact, an even better description of the ethical question comes from Dr. David Eddy. In a major series that he published, 26 articles for the Journal of the American Medical Association, since pulled together into a single volume called Clinical Decision Making. In the last 3 articles in that series, he addresses exactly this same question. You see, it's not that I'm obligated to deliver maximum benefit. The real ethical consideration is that I do not withhold a benefit, a potential benefit, regardless of cost, without involving the patient in the discussion. In fact, there are many circumstances, even in a maximalist approach, where I don't supply all possible resources. The patient chooses not to subject themselves to that particular approach or treatment. Well, when I translate that to a population level, yeah, I have to ask that group of patients how they want to allocate their resources. Those resources they could spend on education, which has a major health benefit, just in passing, or on food and shelter, or on their own enjoyment of vacation, comfort, other parts of their lives, how much they want to allocate to health care. It's a decision that we really can't make for them. We can, though, frame the issue, and as patient advocates help them to understand we can, of course, participate as citizens in the country ourselves. But when we start to talk about a shared social benefit, healthcare purchased through insurance, where we all participate, these other ethical issues start to play a much more prominent role. If we tie all three elements together, then it looks like this. We have three explicit mechanisms where clinical outcomes drive cost outcomes. The first two are technically labeled waste: quality waste and inefficiency waste. For quality waste, as our quality goes up, it causes our costs to drop, a win-win, and it's big. A minimum of 25% of all costs of operations of healthcare. It's probably over 50%. The second category, inefficiency waste. Yeah, win break even. Same clinical outcomes but lower costs, freeing resources to use for other purposes. Again, it's big, much, much harder to get at, but yeah, Dr. Roberts estimated in the extreme 50% of any process, clinical or not, falls into this category with sufficient time, with sufficient understanding. And then the big ugly, cost benefit. Yeah, there we're forced into a very difficult circumstance of judging how much we should spend to get a particular benefit. And the whole point is, at that level, it's no longer our decision. Think of it this way. What's the framework in which these changes occur? Well, for quality waste, it's entirely internal. We don't have to ask patients if we should reduce failure rates and save them money by not harming them in a care delivery process. The same is true for inefficiency waste. Patients would have a uniform desire that we would deliver care in the most efficient way possible so that we can minimize the cost of care, freeing resources for other purposes. It's that last one, though. Now, back during the Clinton era, I participated fairly heavily in the debate over national health care reform. In sitting in many of those meetings in Washington, D.C., you encountered the most interesting attitude. Among them, mostly it was young attorneys who staffed the various House and Senate committees, the executive branch committees, who were involved in devising the plans. They'd seen enough data about waste and inefficiency in healthcare to believe that if we could somehow solve the first two, that we'd never have to face up to the third. That if we could eliminate the fraud and the abuse, the silliness and the waste from healthcare, we would have all the necessary resources to deliver all healthcare to anybody who might want it. As you start to carefully examine the forces driving the increases in American healthcare costs, though, you soon discover that that's almost certainly not true. That the forces driving up demand are so strong that they're almost certain to outweigh even all of the waste elimination that we could possibly produce. My favorite source of that information is Dr. Ed Hughes from Northwestern University in Illinois. The biggest source of increase, for example, is aging of the population. It's not just that baby boomer bulge working its way through. It's also something called the failure of success. We've been amazingly successful in discovering ways of, well, treating disease and keeping people alive. You know, they tend to be very sick people. We're keeping people alive who then consume much more healthcare resource. Behind aging of the population, the second biggest factor is new technology. We keep inventing things that really do work, and the list goes down from there. The point is that they're all demand-driven when you look at the entire list, and almost none of them are under direct control of the healthcare delivery system. I guess this is the point, though. In a very real sense, we as healing professionals are caught between a rock and a hard place. Yeah, the rock is well-documented levels of waste within the system. The hard place, oh, that cost-benefit problem. Yeah, and we're slowly being ground to pieces. I guess I would say it this way. Is it possible to be an ethical physician, an ethical nurse, and not think about cost? You know, every time I waste resources on this patient over here, those are resources that are then not available to the benefit of this other patient over here. You see? Cost is in every equation from an ethical viewpoint. When we have constrained resources, as we so obviously do, we have an obligation, a professional obligation, to find every mechanism that we can to eliminate waste from the system, make care better, and make care cheaper. Quality waste, inefficiency waste should be front and center on every healing professional's agenda. Our purpose in our discussion today was to convince you that your clinical outcomes causally relate to your cost outcomes. In a more realistic sense, that your clinical quality drives your cost results. It drives not just your cost results, but your organizational survivability and your ability to meet ethical requirements to supply the best care to patients at the lowest necessary costs. Have we convinced you? 3 hard causal mechanisms: quality waste, inefficiency waste, cost benefit, mechanisms that you can manipulate to the benefit of your organization, certainly the benefit of our professions, but also to the benefits of your patients.